All right.
Yes, Dr. Sim, can I start?
जी डॉक्टर महाम आप स्टार्ट करें.
Okay, so starting with the first case, this is a case of a 68-year-old male, right-handed KPS 90. He presented with complaints of forgetfulness and generalized weakness. Initial MRI brain was noted left temporal lesion. It was multifocal and there was a cystic component with cystic lesion with necrotic component. He underwent NNG-guided left temporal craniotomy and maximal safe resection. Post-op MRI was done next day of surgery that showed post-surgical changes and near total resection of the lesion. On histopath, it came out to be astrocytoma grade 4 IDH mutant and Ki67 was 20 to 30%. So this is the initial pre-op scan, and over here we can see on T2 images there's a T2
So, Dr.
hyperintensity.
Ma, we have radiologists are with us now. To Dr. Shumaila, Dr. Shayan, if you kindly comment on
All
the
right.
cases. Thank you.
So डॉक्टर शायान कुछ आप इसमें हमें डिस्कस कर दें, then we can ask Dr. Shumaila.
All right. So in the given sequences, we have axial images. We see abnormal signals in the left temporal lobe, and we see some cystic areas, which some heterogeneous signals and surrounding vasogenic edema. And this edema is extending into the insular cortex as well as into the ipsilateral basal ganglia. And if you look at the contralateral medial temporal lobe, we also appreciate some hyperintense signal over there. So we see abnormal signals in bilateral temporal lobe. These are the T1 which sequences. I think in the top row is the unenhanced T1 and the lower row is post-contrast T1. We can see that there is heterogeneous enhancement in the lesion, and the enhancement is an infiltrative type, showing the aggressiveness of the lesion. However, we do not appreciate any significant enhancement in the contralateral lobe that is on the right side. As we move forward, again, we see heterogeneous enhancement around the cystic lesion. These are the sagittal post-contrast images, volume images, and we can see the infiltrative nature of the lesion. It is showing enhancement, cystic component with areas of necrosis surrounding vasogenic edema, predominantly confined to the temporal lobe. This is the left-sided temporal lobe. Moving forward, we have flare images in the next image. Here we can truly appreciate that we have some on the contralateral lobe as well, though we do not appreciate any enhancement. So this also raises concern, possibly we have some neoplasia on the right side as well. So this is all from my side, and Dr. Shumaila can add.
Yes, Dr. Shumaila, please.
Thank you so much. Yes, I agree with Dr. Shayan that there is an aggressive looking neoplastic lesion in the left temporal lobe, which is extending in the peri-insular region and appears to cross the midline, although the contralateral lesion does not show the typical enhancement pattern we see on the left side, but still the edema on flare is very convincing that it is crossing the midline. It has heterogeneity, it has cystic solid component. It is showing multifocal areas of enhancement. We can see areas of nodular enhancement, especially if you look at the sagittal T2 weighted images, we can see that there's the wall of the cyst shows nodularity along the enhancement. It's not a smoothly homogeneous enhancing peripheral wall. It has multiple nodular areas, plus the enhancement is multifocal. And then there are tiny nodular enhancing areas in the periphery of this edema. The edema is vasogenic. And also another thing is that if you go at the flare coronal images, we can see that there is descending tentorial herniation, which is important to point out, because if you see the last image in the first row, you can appreciate that along the tentorium, there is descending tentorial herniation. And this is appreciable also on the T2 weighted axial images where we can see effacement of the basal cisterns. And diffusion weighted images and susceptibility are important to look at, which we do not have right now, but I'm sure that there must be susceptibility in this region because it appears to be quite aggressive. So I will agree with Dr. Shan that this appears to be a high-grade astrocytoma. And the features, I must say that everybody should keep these features in mind because the next case has slightly different features. So we will be able to compare that how we grade different neoplastic lesions on the basis of MRI.
Thank you.
Thank you.
Now we can, I think, Dr. Shumaila, we can continue with you with the post-op MRI. Dr. Shumaila, would you like to comment on post-op MRI? Can you hear me?
Yes.
Okay, please. If you, sorry, Dr. Shumaila की आवाज नहीं आ रही थी मुझे.
Ji, can you hear me now? Because I was unable to unmute myself. Can you hear me
Okay,
now?
yes, जी, Dr. Shumaila, आ रही है
Should I
आवाज.
continue or Dr. Shayan will
जी,
continue?
please, आप continue कर लें, फिर
जी,
Dr. Shayan पे
ठीक,
है.
ठीक है. So as it was discussed that the surgery was done on 21st of June and it is a post-op scan in the first 24 hours. So I can appreciate that there are post-surgical changes in the scalp and soft tissues and craniotomy, flap and everything. There, if I focus on the post contrast images because they give a better picture. So if you just go to the next post-op images and go to the sagittal images, which give a better picture. So we can appreciate that most of the enhancing lesion is resected. In these images, the cystic component is also showing regression in size. There were multiple enhancing areas. Probably they are removed, most of them. There are few enhancing areas. If we look at the second image in the first row, that there are few areas of enhancement along the superior aspect of this lesion, which are still there. So there is, I would say, near complete or partial resection of the tumor along with post-surgical changes.
Thank you. Dr. Shayan.
I have nothing to add.
Thank you. Okay, and Dr. Shumaila, my question, what do you think about the flare? And when you have high-grade lesion, do you look at the flare after post-op also, like it has the importance?
Yes, I do look at the flare images. It does have importance, but in immediate post-op, because the post-operative edema and rest of the things,
Right.
they are quite marked, although they are less in 24 hours, but still, due to post-operative skin thickening and rest of the material, we at least I focus more on T1 weighted post-contrast. But
Okay.
when later on, for example, in post-radiotherapy cases, when they come to us, since I work in CyberKnife, so this flare sequence is very helpful because the extent of vasogenic edema and the extent of involvement, it becomes more clear on even on our radiotherapy. When we plan a patient for radiotherapy, we keep flare sequences also on our planner.
Okay, perfect. So now I think Dr. Shumaila made this excellent point so that I can ask Dr. Asim to give his opinion for the radiation, and in this patient, what will be your recommendation?
So considering the histopathology report of high-grade astrocytoma, this patient definitely requires chemoradiation therapy. However, as pointed by Dr. Shumaila, the challenges of incorporating the flare changes in your peripheral volume. That is a challenge. So one of the reason actually to present here this thing is that because this is the challenge being a radiation oncology we usually come across. Because if you look at the MRI scan, you can appreciate that there's a large lesion on the left side with enhancing component, but there are also changes on the contralateral side as well in the temporal lobe. So, so that would be definitely the challenge because as the volume increases, that the probability of toxicity also increases. The other thing would be I would have a question from our our radiology colleague regarding, is it this type of radiology can just fall under category of dermatosis cerebri, or we still think that it is a localized disease?
Right. Okay.
So, as
Can
far as yes, I would like to add to this
yes,
question.
yes.
As far as my knowledge from books is that number one, we do not use this term dermatosis cerebri anymore according to the new classification, but still there is involvement of more than two lobes, more than three lobes goes in favor of that. But the thing is that we do not have only flare-based involvement. We have an other associated aggressive-looking component. So calling this lesion as, I mean, if we did not have this cystic component, this nodular enhancement, so probably we would have called it gliomatosis cerebri in old terminology. But since we have aggressive-looking enhancing multifocal areas, so calling it gliomatosis cerebri becomes a little tricky. So I wouldn't have called it. I would have called it an aggressive lesion with this and this kind of enhancement crossing and the edema crossing the midline, because gliomatosis do not get this kind of cystic components and enhancing nodular areas the way we have in this region.
So thank you, Dr. Sumaila. Dr. would you like to add something?
I try to look whether it is in continuation with the primary or index lesion, but I could not see any continuity because it is not crossing through the corticospinal tracts. Probably it is a skip lesion. It is not in continuation with the primary lesion. So it can be a totally separate lesion. And there's no definite involvement of the corpus callosum here. And so probably we are dealing with some multicentric tumor rather than a single tumor. So that is the question, because these are not volume images and we are not able to appreciate any continuity here.
Thank you, Dr. Chan and Dr. Kumar, your valuable comments. So because if you look at the literature and in our practices, we come across these kind of cases where you can find the flare changes that is sometimes crossing the midline. So if it is in the continuation with the enhancing component and crossing the midline, and it is it is very obvious that it is related to somehow the tumor itself. But like this region where you have changes in the contralateral lobe, which have no connection with the primary lesion, these are tricky things. So as I mentioned earlier, because the challenges from radiation perspective is to include all these changes in the volume, because it is very difficult to exclude things, whether it is only the neoplastic process or simply the other process. But in the background of this thing, it's very difficult to actually exclude it. The other the important thing is that because there in our practices we have seen cases where there is no enhancing component associated with the flare changes, but the flare changes is here before low grade glioma. If we look at the literature also shows, or there are also case reports or case series mentioned about the low grade glioma that has also this kind of infiltrated as well. So definitely, Dr. Hassan, it is a challenging case from a radiation point of view because we cannot actually skip the contralateral looking at the flare changes and all these things. But one of the important things is that what are the options we have available apart from the recommended one, that is radiation therapy. So if we have any medical oncology,
I think Dr. Adnan has joined us. I can see him. I'll ask him. One thing I want to add here, since we are having very with the radiologists, and I'm very thankful to them for this educational discussions. So my understanding of these kind of tumors is when I have different kind of contrast enhancement, but on flare, these contrast enhancements are connected through flare. I think in my mind is the same tumor, but with different focus. Like I call it multi-focus. And if the flare is not connecting those two different contrast enhancing or aggressive looking part, then in my mind, I think of this as like two different, like multi-centric. Do we use this terminology in our reporting or we do not use? This is just I'm sharing that's how, I process in my mind when planning for these things. Dr. Shumaila or Dr. Shayan, like, yes.
Yes, when I look at lesions which are, not connecting, I do use this is a multicentric lesion, but
Yeah.
we see over time, because we at CyberKnife, we are since 2013 we are getting routine follow-ups of our patients, and later on when we look at the images, we get to know that ultimately they connect with each other. The lesions tend to connect with each other. So probably we are unable to see, and these are multi centric lesions, but probably at subcellular level there are connections which are not visible, and there are so many things underlying. For example, it depends how the technician gave the contrast, the timings of giving contrast, the concentration of contrast, because there are many times when the contrast is diluted and not given in appropriate doses. So there are multiple factors during imaging, because the imaging is not ideal all of the time. But in that, additional sequences are very helpful, because this imaging is not only limited to T1, T2, and post contrast T1. The additional sequences like diffusion is very helpful, like DTI is helpful, like susceptibility is very helpful, extremely helpful in deciding the aggressive nature of lesion, and is it multicentric, or these areas of internal susceptibility are connected to each other. So I guess looking at the DICOM images give us quite an extensive information, and even in post treatment, post radiotherapy images, for example after CyberKnife or tomotherapy, we are able to delineate that is there radiation necrosis, is it residual lesion. Many a times still there are tricky cases when we get stuck over there, but more or less the imaging is quite advanced, and we are able to give quite into our neurosurgery colleagues.
Thank you. So we have Dr. Adnan Jabbar with us. Sir, Assalamu alaikum. So,
Walaikum assalam.
thank you for joining us, sir. Sir, this is a high-grade tumor, so wanted your opinion for systemic therapy, chemotherapy.
I'm sorry, I joined in the middle. How old is the patient? And the biopsy has confirmed it?
Yeah, I'll take you to the first. So it's 68-year-old male, and the
Yeah,
biopsy was astrocytoma WHO grade 4 IDH mutant, okay, 67,
yeah.
20% to 30%.
Right. So the main question is going to be for my colleagues, if they're going, the radiation oncologist colleagues, that if they are going to incorporate radiation, because looking at this, there's going to be a wide area that will need radiation. Certainly, this patient will require temozolomide. But the question that I will have, and I don't know if you guys have already discussed radiation, Asim, it seems like a huge area. What would be your stance on giving radiation?
So thank you, Dr. Khan. We had a discussion about this thing because it is that this is that diffusely involves the contralateral side as well. So because radiation therapy is indicated in this particular patient, but the question that we have in our mind is that because our volume has actually a bigger as compared to what we are usually used to treat. So that's why, but looking because it's a high grade component, I would incline towards offering incorporating radiation therapy in the plan because of this enhancing component. The one thing is that the important thing is that though it is in the contralateral lobe, but it is lying very close proximity to the what is actually the region is. So it is the volume would be increased in my case, but we can actually incorporate. But the question is here, Dr. Dankina, because we have some cases with you as well where there's a diffuse changes, and is there a possibility of considering chemotherapy alone and preserving the radiation therapy in case if there is a progression on the chemotherapy?
Dr. Adnan, sir,
तो मेरी आवाज आ रही थी आप लोगों को?
जी
Am I audible?
आप क्या रही?
Sorry about that.
Yeah.
So, what I was saying is that giving chemotherapy alone is always an option, but we know that when you give chemotherapy alone, it is not as good as compared to when you're giving it with radiation and following it. So certainly, that is always a challenge when you tell me that a patient who is not able to get radiation, despite knowing that he or she has high-grade glioma. So, in a patient like this, I don't think I will be sparing radiation with the aim that I can save it for later. But I guess I understand your challenge that there's a large area where if you radiate, there might be consequences of that. Um, we can certainly start with single agent temozolomide. That is something that we do. For a patient like this, I can even add single agent temozolomide. I think I would just certainly then consider single agent if you will not incorporate radiation. Ideally, one should, but for elderly who are not able to, there's clearly data that you can give single agent chemotherapy as well.
Thank you, Dr. Adnan. So, Dr. Munib with us. So, Dr. Munib, am I audible to you? So, Dr. Munib, the MGMT status, I don't think so it has been done for this particular patient. We only have the IDH status available. So, as mentioned by Dr. Adnan, and also because of the high grade lesion, I would also more inclined to offering the combining the two, the concurrent chemoradiation therapy. So, regarding the volume, because you have seen that it is multifocal or multi-centric disease, so what volume would you consider depending upon the radiological finding?
But I was asking because usually in my practice that those patients who were MD methylated status were positive basically. So we used to give temozolomide only to those patients who had poor performance status and MGMT positive. I don't know because I saw on the first slide it's a good performance status patient. In I would ask what will be your practice in terms of fractionation, like 16:30 versus 14:15, because the Astro IDH mutated, they have a better prognosis than the GBM.
So, regarding because this is IDH muted tumor, definitely, and the patient performance is also not very bad. So, I would more incline towards offering the conventional form of radiation therapy. The other thing is because the volume is big. So, when you are dealing with the big or large volume, it is better to the dose perfection need to be in a conventional rather than a people hypofractionated form of radiation therapy. So definitely I would incline towards offering radiation therapy in the conventional form in 32 fraction to 33 fraction, uh, uh, depending upon the doses to the surrounding structures for that risk.
So, if I may add regarding methylated and unmethylated status, we all know the data that temozolomide work better in one versus other. But currently, if you look at the standard of care, temozolomide is the first option in either cases. Patients who were unmethylated, there is data where they used Avastin, bevacizumab, along with carmustine. But even to date, I think temozolomide is the first choice, irrespective of the status. The they use in these patients is clinical trial, meaning they still do not have a best option in patients who are unmethylated. So yes, it is good to know. Yes, we know the prognosis because now it becomes a predictive marker. MGMT is a predictive marker, which tells you what will be the outcome in patients who have this and their response to temozolomide. For I don't know if you have residents or students. if you have methylation, the enzyme becomes silenced, and hence it is not expressed and does not break down temozolomide as effectively as patients who have unmethylated MGMT. So the standard of care is still concurrent chemotherapy with temozolomide unless you have a clinical trial. Are you guys using something else, Hunif, over there? Were you guys using something else in unmethylated?
Dr. Munib,
I think we lost him. We can ask him that question later on.
all right. So now we can move to the next case, Dr. Asim.
Yeah, sure, doctor. So for this case, the suggested treatment modality would be the concurrent chemoradiation. Considering the high grade, the performance status of the discussion on the radiologic findings.
Agree.
All right. So, Dr. Maham, would you be presenting this case?
Yes, I'll be presenting this case.
All right.
So the next case is of a 26-year-old gentleman. He was ECOG1, presented with complaints of severe headache and rapid deterioration of the vision. That showed a diffuse negative lesion involving the corpus callosum, and it was showing infiltration into the adjacent cerebral hemispheres without any discrete enhancement. He underwent surgery. It was an NG-guided craniotomy and maximal teres resection, and post-op MRI was done that showed interval increase in the infiltrative component. Next slide, please. So this is the pre-op MRI brain. I'd like radiology to comment on the scans, please.
Dr. Shayan, if you can.
Or these are limited images. The top row is a post-contrast T1 sequence. Here we can, I think I should interpret the lower row first. These are T2-weighted sequence. Here we can see a diffusely infiltrative lesion, hyperintense signal involving predominantly the corpus callosum, and it is extending in the periphery, in the subcortical white matter, as well as involving the cortex. And posteriorly, it is extending into the corona radiata and involving the frontoparietal lobe, and if we go inferiorly, it is involving the temporal lobes as well. It is very ill-defined, and we cannot draw a line. It is not very well demarcated. And in the top row, this is a post-contrast T1 sequence. Here we do not, it intense, and we do not appreciate any discrete enhancement within the lesion apart from the normal enhancement of the vessels. All you can see are the normal enhancing vessels in this region. All right, so these are on the left post-contrast coronal and sagittal sequences. Again, we do not appreciate any discrete enhancement within the lesion. This is all hypointense, diffusely infiltrative lesion. And on the right, we can see this is a sagittal sequence, T2 weighted, showing the infiltrative nature of the lesion involving the frontoparietal and temporal lobe. So based on this, this looks like a diffuse lesion without any significant enhancement. And this has a pattern of gliomatosis cerebri, and looks like a diffuse astrocytoma without any definite enhancement. So Dr. Shumaila can add.
Yes. Dr. Shumaila, please.
I agree with Dr. Shayan. So, like, here is the difference between imaging pattern of the previous lesion and this lesion. And if you use the terminology of gliomatous cerebri, we can use it in this lesion because there is diffuse edema which is crossing the midline involving more than 3 lobes. And then if you look at the enhancement pattern as compared to the previous scan is very different. It's not enhancing discretely. There are no cystic areas, there are no solid enhancing areas. So this is the difference. These features differentiate between the grades of the lesions. Like the previous lesions was a high grade astrocytoma, as was histopathologically proven. So in this lesion, yes, I will call it a diffuse intermediate kind of astrocytoma instead of calling it a very high grade glioma. Although if we look at the sagittal intubated images, we can appreciate that it is crossing through the corpus callosum. If the appearances have been this, but there had been, enhancing areas, solid enhancing areas in different restrictions, and no necrosis, so I would have considered lymphoma also. But since there is no enhancement in this, and because there are only 3 to 4 differentials for lesions which are crossing corpus callosum. One is high grade astrocytoma, the other is this gliomatosis cerebri, the third one is radiation necrosis, then there is lymphoma, and the last is infection, which can be in any form anywhere. So these are the differentials for lesions crossing the midline. So I agree with Dr. Khan.
Thank you.
Okay.
And Dr. Maha, was it like you said, maximal safe resection? So they did the bilaterally, or do we have any notes from? Okay, we can see.
So Dr. Hassan, I would like to add, this patient only had a biopsy.
Yeah.
Because
Okay.
looking at the extent of the lesion, they would only take the biopsy to confirm the diagnosis.
Yeah, thank you for clearing that. So that was my question. So because maximal safe resection would be a little bit more aggressive in this. Okay. So Dr. Shayan, over to you. So for this post-op MRI.
Probably they have just done a biopsy,
Yeah.
and they did a mini frontal craniotomy, and you can appreciate a surgical track on the right side and post-op changes. So nothing much to
Okay.
add.
And so the biopsy showed astrocytoma grade 3. Right. Okay.
Yes, so on histopathology, it was astrocytoma grade 3.
Okay.
1p19q co-deletion was not detected. IDH1, IDH2, and MGMT promoter methylation was not detected as well.
Thank you.
And we do not have any FLAIR images for this, right? Only T2 and T1 and post-contrast. Because we were discussing the significance of FLAIR imaging, but I cannot see any FLAIR images so far in this case.
Right, I think. So, Dr. Shomaila, would you like to add something in this post-op? Do you see any?
No, I think the size is more or less the same. They are just post-surgical right frontal lobe. I was just wondering that the shape of skull on sagittal is due to imaging, or there is some craniosynostosis also. Just looking at the lateral things, which is irrelevant, but I was just focusing on sagittal images, and I could see that it is, a very tower-shaped skull. So I was just wondering that probably the coronal suture is fused, because I couldn't see that, but these are very limited images. Otherwise, only post-surgical changes in the right frontal lobe and not much.
Thank you.
Yeah.
We can take Dr. Adnan's opinion now. So, sir.
No, that's it. So, I mean, again, we will basically, similarly like the previous one, first question would be, what would radiation oncology like to do? Because certainly we will give temozolomide, and that would be good.
So looking at the scan, this case is different from the previous one, where it's a very high-grade component, though there is another lesion on the contralateral side, but the volume is not so high. But here, if we look at the scan, and as I mentioned by our respected radiologist, it is almost involving the whole frame. Okay, so this sort of of radiological findings. There is a diffuse pattern of density changes. Usually, the minimum that is required for this patient is exactly the whole plane, because it cannot actually limit the area that would not be get treated. So I would more incline because one of the important things is that, as is in the histopathology finding, is that because this IDH wild type and the promoter is also not detected, and plus 1p19q correlation is not as well. So all these features, despite it is a grade 3, but all this suggestive of molecularly high grade region, and the patient is very symptomatic in terms of the blurring of the vision and all these things. So I would incline or would actually recommend actually radiation therapy to this particular patient, and the my volume would be is actually the whole brain. Because in the sagittal image we can see the only the brain stem is brain stem, and the cerebral portion is a little bit spared. Otherwise, the whole supratentorial area is involved by these changes. So Munib, would you like to add something on this particular case? Dr. Munib? I think he has some connection issue. So we can proceed from yes, Dr. Hadan, I will definitely incorporate radiation therapy in this patient.
So I have one question. I mean, what was the timing of this scan? Because we all know that there's and if and I think I'm just thinking out loud that a study can be done where you give these patients perhaps maybe Avastin, a couple of doses of Avastin, or post high dose steroids and see if there's a change in your volume. I don't know. I'm just thinking out loud because I don't think we have that kind of data that whether your T2 flare will change after giving these agents, which reduce your this flare over there and edema over there. Would that help? I don't know. This is just thinking out loud.
I think that's a very valid point, sir, about the steroids, especially. Like, I think I have my threshold low in these patients to give, the steroid. Sometimes I have seen they do get better. And we also have noticed, and the imaging, like the edema also reduces. But yeah, Dr. Asim, would you like to add some, sir?
So definitely this is a challenge, and we are always looking for the excuses and always discuss with our medical oncologists how to actually, because these are it's really a challenge, covering all these things with your additional volumes. So if you look at the data, unfortunately, the data is not there. I mentioned by Dr. Khan as well. As if you're also looking at our additional oncology data, there's also only the case studies to deal with this and in some studies, you find with a whole brain radiation therapy. In other cases, for trying to have a localized, though we are talking about a localized brain treatment, but still it is the bigger one. So it is very difficult. Yes, we can do, but usually, if as mentioned by in our previous case as well, is actually something not very mimicking although it is mimicking the diadematous component, but the flare change is suggestive of tumor infiltration. Because if we look at our data both from the guidelines perspective, it is always initially all incorporate these flare changes in our volume. Though the higher grade tumor, the term T2 type of changes has been decreased. Now we are only focusing on the flare changes because T2 sometimes is mixing with the elements. We have a raised hand by Dr. Shayan. If Dr. Shayan would
Yeah.
I have a question to the board. Though I'm not expert in this field, I was just reading about these tumors. Ideally, these tumors, since they are IDH not mutated, and these should total resection followed by a good radiation dose, and these mostly they do not respond to temozolomide because they are not methylated as well. But in this case, since this is a very young patient, and having a very diffuse abnormality, and we cannot offer him gross total resection and apart from a good radiation dose. So is there any role of immunotherapy or any targeted therapy we can offer him?
Unfortunately, there is CNS was the only area where immunotherapy did not show any benefit. Unfortunately, so currently there is no targeted therapy. There have been a lot of studies that were given where you had EGFR directed therapy, except for the one where you have IDH mutation and they are positive. Those are the only cases where in low grade you have an IDH mutation inhibitor that has shown some result. But for high grades, currently immunotherapy has not shown any benefit.
Thank you. So, Dr. Asim, we have a request from Dr. Mehboob Alam, who has joined us from Awa, Kent. He also has one case. Can we quickly add his case? If we still have, like 10 minutes
Sure,
remaining.
Dr. Hassan. If we could, sure, we can proceed from his case.
Sir, can I have a quick question?
Sure,
Yes,
sure.
sure.
Dr. Mehboob,
So
you can, I have made
I'm Dr. Adnan. I'm consultant clinical oncologist at CMH Rawalpindi. Basically, pertinent to the last case, I have a question that high-grade astrocytoma, we are going with the concurrent chemoradiation therapy in this case. What would be the number of adjuvant cycles here? Would we go for the 12 cycles here, or we will just restrict ourselves to the 6 cycles? I would like to ask Dr. Adnan about that.
So for high grade, we know that more than 6 cycles have not shown any benefit. It's like quite contrary to what one would think. For low grade, it's 12 months. For high grade, it's 6 months. I was very specific in my question when I went to ASCO last year, and I asked during a neuro session, what about patients where they have some residual disease? Would you still consider giving them? And I'm blocking on his name. There's this Indian guy who has taken part in our previous neuro-oncology sessions as well. And he was very specific that he sticks with 6 months and he stops. I personally in the past had used for patients who had gross residual disease going beyond 6 months. But based on the data, they typically are recommending 6 months in high-grade gliomas, and if you have low-grade, 12 months.
Okay, thank you. Dr. Mehboob, sir, आप unmute भी कर लें. We can see the screen.
Yes, Assalamualaikum. Sorry, I'm late, or I'll try to be as brief as possible. This is a young lady, 39-year-old. She presented to us back in 2021 with frontal lobe symptoms and fits. So this was her symptoms. So on examination, she had subtle cognitive impairment. Other than that, she had got papilledema, but otherwise she was fine. So this is her pre-op MRI. Let me do it like this. Yes. So I've just selected images. So this was her pre-op MRI back in December 2021. So radiologist would like to comment, or should I proceed? Okay.
So we have T2 weighted axial images, flare axial, T1 plane, and post contrast axial in one by one. So on T2 weighted images, I can appreciate that there is a large abnormal signal intensity area centered on the right frontal lobe, which is crossing through the genio corpus callosum probably. It has a central cystic area, which is T2 hyperintense. Rest of the area is mostly T2 iso-intense with few rounded, relatively T2 low signal area. And on FLAIR, I can appreciate that there is all pathological vasogenic edema which is crossing through the midline. There is associated subfalcine herniation, a lot of mass effect on the adjacent ipsilateral lateral ventricle, and the frontal horn of contralateral lateral ventricle is also showing compression. There is some subependymal seepage along the occipital horn of left lateral ventricle. On T1 weighted images, there are few internal hyperintensities, probably areas of hemorrhage, which are seen along the anterior aspect, which are low on T2 weighted images. And then I can see that it is showing some peripheral enhancement of the cystic component, which is nodular, irregular. It is not a well-defined cystic area. It is very bizarre shape. And then enhancement in the anterior rounded aspect adjacent to this bizarre shaped cystic area. So it's probably a high-grade aggressive neoplastic lesion. And then we have another set of images from a little different level in which more or less the changes are the same. Areas of vasogenic edema, areas of heterogeneous enhancement, and then compression, subfalcine herniation. So it appears to be a high-grade astrocytoma.
So just to be brief, we did a neuronavigation guided craniotomy in February 2022, and the histopathology came out to be a diffuse astrocytoma, IDH mutant grade 2, and rest of the parameters are mentioned there. GFIP was positive, P53, PECI positive, ATRX loss of IDH was positive, and Ki67 was up to 5%. So since we don't have an oncology service over here, so we referred her to oncologist. So she received after the surgery, 6 weeks after the surgery, she received this treatment: CRT 10 cycles and chemo temozolomide for 7 cycles. So this is her post chemo and radio MRI.
I'm sorry to interrupt. Can you explain what do you mean 10 cycles with CCRT? I'm sorry, if you go back one slide. These 10 cycles with CCRT.
Yeah. Chemoradiotherapy, basically. She received concurrent temozolomide as well as whole brain radiation. That's what
Okay, because there are no cycles, it's given daily with radiation. So every day that you get radiation, you get temozolomide.
No, she got 7 cycles, 5 days a month first. Of temozolomide.
Okay.
And yes, so this is post-op MRI after 6 weeks, just before the radiation was started. So radiologist comments, please.
So definitely the bulk of the lesion has reduced. There is the mass effect and the subfalcine herniation, they have also reduced. But there's a new lesion, new enhancing lesion in the contralateral, because the vasogenic edema was already there on the other side. But I can appreciate that the enhancement pattern on the other side has changed its characteristics. Even the enhancement of the right frontal side has a different behavior as compared to the pre-treatment scan. So we will just consider it on 2 lines, that either these are this is a residual lesion or these are post radiotherapy changes. I mean, we just have to on 6 weeks to decide that whether the lesion has completely resolved and these are post radiotherapy changes. It's too early to say.
No, these images are before the start of radiotherapy. That's after 6 weeks.
It's post-op 6 weeks. It's post-op
Yes.
6 weeks, right? So I saw that, yeah. But the enhancement on the contralateral side was not there in the pre-op scans, as far as I remember, because you just shared it. I haven't reviewed the scan before. But as far as I remember from the scans you showed, the contralateral side did not show any enhancement.
Yeah.
But the bulk of lesion has reduced, so probably the dissected component is showing decrease in mass effect and subfalcine herniation, but there is an enhancing component on the other side. I believe that you did not approach surgically to the other side, because I can see post-surgical changes only in the right frontal side.
We did.
So the lesion on the
We did the right side craniotomy and debulking of the right side lesion, not on the left side. We did,
Yes. So probably the lesion which was this is what I was discussing initially with Dr. Ehsan, that at times we, later on in the follow-up scans we are able to see the areas of enhancement in the areas of previously seen vasogenic edema which become more conspicuous. So probably this vasogenic edema which was seen previously has more conspicuous looking lesion, more obvious lesions now. So edema was already there, enhancement wasn't there. So probably this was already, the lesion was already there, which is becoming more evident now.
So after the so this is the post chemo radio scan, July 22, almost 5 months after the completion of radiotherapy, and chemotherapy was still continuing at that point. So these are the images here. These are basically taken through the mobile of the patient, so may not be that clear, but the contralateral lesion has reduced a bit in size.
Yes, both the lesions actually. The right frontal lesion where you resected, but there was some residual. It is showing area of encephalomalacia and gliosis, which is a combination of post-surgical resection as well as post-radiotherapy changes. And then the mass effects, they have significantly reduced. The contralateral lesion is partly showing regression in size. In one of the images, it is very small, but when we look at the region of genio of corpus callosum, we can see some enhancing component, but definitely there is regression.
So we have been following this patient for the last 2-3 years, and the contralateral lesion also settled in this July 24 scan. Here we can see that there is no enhancement, though I didn't share the whole scans, but the point where the lesion was, it is not showing any enhancement. But now the patient has, this is from May 2025. Here we found out that there is some sort of enhancement over here on the contralateral lesion side. And we got an MRI in August 2025. So I'm trying to be brief because we are short in time. So this is the scan from now.
Yes, there is increase in enhancement. I agree with you. In the previous scan, I was just doubtful. I wasn't looking at the right, but the thing is, yes, there is enhancement even on the right side along the inferior and medial aspect of the lesion, anterior to the frontal horn. Yes, I'm not sure that this area was there previously or not, because its behavior is also behaving similar to the behavior on the left frontal lesion. So if you go back one slide from the May, can we see this? So I believe that this area was also smaller, minimal enhancement, and showing some kind of increase along the anterior aspect of bilateral frontal horns, probably.
Yes, it was a bit smaller in size and less enhancing.
Yes, but this is 2 years or 3 years after radiotherapy, right?
Yeah, radiotherapy completed in July 22, yes. So now the question is from our side is that how to go about
So
it.
we have
this lesion.
Thank you, Dr. Mehul. Thank you so much for this wonderful case. I think one of the things that I would think, I'm starting from my kind of not recommendation, my suggestion, like the left one that you can see the contrast enhancing, maybe we can get a biopsy. Maybe there is a great change. Over to Dr. Adnan, sir, what will be your recommendation?
Yeah, certainly that was my thought, that we get that part because it is easily accessible as long as the patient is in good performance status, and uh, removing it will certainly help it. I am not sure my colleagues in radiation oncology, after 2 years, they will certainly like to know whether this area was incorporated initially in the radiation field. Otherwise, temozolomide will have to be restarted for sure.
So idea that means first we need to get a biopsy of that thing to actually confirm the grade of the tumor. The other thing would be actually, as mentioned by Dr. Adnan, I would also, for radiation, we need to actually review the previous radiation treatment fields and all those parameters in order to actually have or give any opinion regarding the further role of radiation therapy. But definitely the way to proceed is actually to biopsy and from there and proceed from there.
Yes, sir.
I would
Just
probably, sorry, I would not use the word biopsy, I would say, because it's an area where you can probably give me maximum safe resection. That would be preference. If you're going in, what do you think? Because rest of the area is pretty stable. So if you can remove as much possible from this part, that would certainly be helpful. Essen?
Yes, sir, definitely. So, first, no, I'm thinking about the left side, left frontal one. That can be taken out. I think Dr. Mehboob agree to that. And what about the right one? So there are some studies I have done once, only this kind of a case where I did two small craniotomies because there were two different lesions and tried to take out, both lesions. So, I mean, at least we need the left frontal, that part should be out, and that can be taken without giving significant neurological deficits.
So, the patient is functional class 1. She's a school teacher. She's back to work. So, a bit of worry from my side that the right frontal lobe is already gone. So, if by chance or by any means she gets some damage to the left frontal lobe, she's going to end up in trouble.
So and now this is a question for Asim. Would you consider SRS for that area?
Important thing they we need to actually review the previous radiation treatment field because the tumor is already the bigger one to start with. So we need all those data to be able to actually see whether we are in a position to actually further our radiation therapy or not. But Dr. Mehboob, the one important thing is that definitely your concern is genuine and you have all the patient condition is definitely need priority. But when we need actually some sort of evidence to what is the grade of the tumor or the thing, and also the molecular status as well to proceed from there. So in order to proceed, we need some molecular and histopathological diagnosis regarding the SRS. If the previous radiation treatment field allow, then one can actually consider depending upon the residual disease and the systemic support we have.
So, I mean, we already have the molecular status. We already had the diagnosis. This is within 2 years. Most likely it is going to be that. And I'm assuming that this area will be included in the radiation field. Would you still consider, because she has had such a good run, 2 years? I mean, she is typical, showing you the typical behavior of a gate 3 astro, where you start seeing these progressions around this interval of time. Um, so what would you? This is just a hypothetical
So
question for you, Asim.
yeah. So Dr. Adnan, as the concern raised by Dr. Mehboob is also actually associated with the radiation therapy as well, because this radiation is already exposed. So if we are targeting this area with a stereotactic radiation therapy, so the doses that is required to actually control this disease status is a little bit lead to the radiation necrosis. So if she develop radiation necrosis in that particular area, then it is also, something very what do you call it, affecting the quality of life of the patient that already concerned by Dr. Mehboob. Yes, it is. One can actually consider radiation therapy to that particular area, but definitely it requires actually the engagement of both the patient in the decision-making process and also the review of the previous radiation treatment pool. Because without reviewing because when we look at the radiation treatment plan, we are also looking at the hot spots. So where are the doses actually getting that? Because, for example, I don't know about the exact dose of this particular patient, but looking at whether they give stop radiation therapy at 54 gray, whether it gives 60 gray, or their dose is something more than that thing. So that all things can contributing. Regarding the role of radiation therapy, yes, there is a role of radiation therapy provided the understand the all the thing associated with the reading in that particular area.
I have Dr. Mehboob, was there any deterioration in any personality changes or psychosocial issues after the previous surgery? Also, the previous surgery needed almost right frontal lobectomy, right? But in this case, you will not be going for the lobectomy. You will be just going for that lesion particular. So what do you think about that? Like if you make like a small corticectomy and get navigation guided to that contrast enhancing part only.
Yeah, that can be done. Actually, the patient has shown significant improvement over the time. To start with, she had got multiple issues, but right now she is perfectly fine, except she has got only one symptom, that is urinary incontinence.
Oh, okay.
Other than that, she is, in terms of behavioral changes, she is fine. She is work, she is teaching at home, she is doing well. So navigation guided biopsy can be taken as per recommendations, but we will discuss with the patient about the pros and cons and proceed accordingly.
Dr. Adnan, do you
Assalamu
give anti-anxiety or antidepressants in such patients? Or you just thought, because I wanted to run a trial, just could not do it. So, but I think you knew it. I discussed with you also. So if you get these patients in your clinic, would you think of those agents?
Certainly for depression, we do address them, and for anxiety as well. There is a very high prevalence of depression in these patients, especially people who are, type A personality, people who were independent in the past, and now all of a sudden their lifestyle has become so dependent. So yes, I a very low threshold for adding antidepressants in these patients. And along with that, we used to have a psychologist for psychotherapy, and they would go to these clinics regularly. Unfortunately, here we don't have that component. Our family members are our psychotherapists. So yes, the answer to your question is one should incorporate antidepressants and address it, because many times you don't even talk about it. And you'll see the patients, they become mute, they don't take part in conversations as they would initially. A lot of people do talk about a change in personality, that, now he has become very quiet, he doesn't talk to people, he doesn't respond. So antidepressants should be incorporated.
And there are interesting preclinical studies, animal studies that have shown like even depressants can have synergistic effect with when combined with temozolomide. That was quite surprising for me. No trial, no human data, only studies coming from the lab. So
That would be a very good study if you just do a depression scale on these patients, before surgery, after surgery, and then 6 months later. That would be a great data set.
so Dr. Mehboob, I
Can I add a
think
comment?
sure, sure.
Assalamu alaikum, Dr. Adnan. Sorry, I missed in between. I was having
No
issues
worries.
with the. I missed a bit conversation just to make sure that if radiologists are not sure or whether MRI perfusion will help between radiation necrosis versus the true progression. The second comment is I agree with Dr. I would like to see the previous radiation field and doses, because I heard somewhere that whole brain radiation therapy was given. So I would like to see the previous doses and areas and DICOM images. The third part is I agree that biopsy should be taken, because if it has done to a high grade one, so there is a phase 2 trial that gave the re-radiation, and in that trial the radiation doses were different in 10 fractions and with a very small volume. And yes, SRS can be given considering the small area, but I would like to see the biopsy first. And in my preference, I will go with the re-radiation doses.
Thank you, Doctor. Thank you. So, Dr. Mehboob, I think the plan is what you just mentioned, like you'll discuss with the patient, you'll discuss the option of the biopsy, like neuronavigation guided invasive to get that so that at least we have tissue diagnosis. Otherwise, what Dr. Adnan has already mentioned, the options.
Yes.
Any further questions would you like to ask to the board?
No, it's enough. Thank you for adding me because it was a last minute addition.
Yeah, no, you're most welcome. And we have shared, so for all the panelists, thank you so much for joining us. We have shared the next 3 months dates also on the website of PANS. And if you have any cases and want to invite any other